Welcome. We're so glad you're here with us for today's Harper Lecture. The Harper Lecture series began in 1979 with Hannah Holborn Gray speaking in San Francisco. As the need for critical thought remains apparent in all areas of life, we proudly continue this signature program to bring you stimulating conversations and fresh ideas. Thank you once more for joining us. We couldn't do this without you.
Good evening, everyone, and welcome to the Chicago Harper Lecture. My name is Carol Kopasky. I received my bachelor's degree at the University of Chicago in 2007 as a physics major, and I came back to get my PhD in microbiology, which I graduated in 2014. So excited to be in this room with Chicago alumni and affiliated people for the first time in almost 3 years since we've had a Harper Lecture in person. I'm very excited to see you all in this room today. I have the honor of serving on our alumni board as the liaison for the Medical and Biological Sciences Alumni Association, as well as serving as vice president of the MBSAA program for the last year. And it's my great pleasure to welcome you all to our Harper Lecture tonight. Tonight we celebrate the University of Chicago community by continuing the tradition of relentless pursuit of knowledge, critical thought, and the life of the mind. This evening, we're delighted to have Dr. Harriet de Wit, professor of psychiatry and behavioral neuroscience, joining us today to share her research. She obtained her PhD in experimental psychology from Concordia University in Montreal, Canada, in 1981. Since then, she's been associated with the Department of Psychiatry at the University of Chicago, where she's currently director of the Human Behavior Pharmacology Laboratory. In addition to her role as principal investigator for several NIH-funded research projects, Dr. de Wit serves as field editor for the Journal of Psychopharmacology and deputy editor for alcoholism, clinical and experimental research. She's a consultant to the Food and Drug Administration and serves on several scientific advisory boards at other institutions. She's received several awards for her research, including the Solvay Award for Outstanding Basic Pharmacopsychology Research in Affective Disorders, and the Marion W. Fishman Memorial Leadership Award, and the European Behavioral Pharmacology Society Distinguished Investigator Award. We look forward to opening the floor to the audience for questions later in our program today, so please hold on to your questions. We will save time for those today. And for now, please join me in welcoming Dr. de Wit to the stage. Thank you all.
Thank you. Thank you, Carol, for the introduction. And it's a pleasure and an honor to be here, and I'm glad to see everybody in person. It's a welcome change to what we've been living with. So this is the title of my talk: Old Trips, New Destinations, Recent Research with Psychoactive Drugs. And I'd like to talk about the research that we've been doing in my laboratory over the last several years. And we've been studying the effects of several drugs that are best known for their recreational or non-medical use, but they've received a lot of attention recently as potential medications for psychiatric conditions. Drug use, people have been using drugs since there has been recorded history. Drug use has been depicted in art, as I'm sure you're aware, throughout the ages, as in these two examples of wine use, first of all by Egyptians in the 3rd millennium BC, and then on the right-hand side, a painting of Bacchus, or Dionysus, the Greek god of wine and the good life, done by Caravaggio in the 16th century. And there are many wonderful examples. If you ever go to the Art Institute with this perspective in mind, you'll see examples of drug use throughout the ages. People use drugs for many different reasons. And the reasons probably do vary according to the type of drug that we're talking about. In the case of alcohol, for example, people report using alcohol to enhance their social enjoyment, to produce euphoria and feelings of well-being. Paradoxically, some people say they use alcohol to feel stimulated, and other people use it to feel sedated. So a range of reasons, even with a single drug, people give many reasons for using the drugs. Another category of popular drugs is psychedelic drugs, and the reasons for using psychedelic drugs are quite different. These drugs change perceptions and produce profound altered states of consciousness. And people say they use these drugs for several reasons: for curiosity, self-discovery, and spiritual experiences. One other category is more familiar drugs like tobacco and caffeine. These drugs are used in the fabric of our normal daily lives without causing any disruptions, and people use drugs like nicotine and caffeine for habit, out of social customs, or to improve their cognitive performance. And finally, some drugs like MDMA or ecstasy are used by young adults in very social situations, in raves and in party situations, and purportedly to enhance both sensory and social experiences. So these are some examples of non-medical use of drugs, so reasons people use drugs in non-medical situations. And you can see they're quite varied, and is there anything we can say that they have in common? And so one thing that we can say that they have in common is that they take the individual basically from a normal state to a different and more desirable state. So that's kind of a way to conceptualize recreational use, that it takes you from normal to something new. Some drugs, in some of the same drugs, and that's what my message is going to be here, some of the same drugs also have uses that we consider medically desirable, such as taking drugs to stay awake, or vigilance. People often use stimulant drugs, and even in a therapeutic situation, to stay awake. On the other hand, they can take drugs to fall asleep and to help them for insomnia. Relieving stress, anxiolytic, antidepressant effects. So you can see that there are some commonalities between the type of effects that are being targeted in these medical contexts. They share some characteristics with the non-medical uses. The way we can kind of summarize the medical uses is they take you from an abnormal or an unpleasant state to a normal state. So that's, again, just a way to think about the non-medical versus medical use. But the distinction between medical and non-medical use is not always clear. So we talked about, on the left-hand side, feelings of stimulation after some drugs, and then on the right-hand side here, staying awake is more on the medical side of things. Relaxation on the left, and then falling asleep on the right. So you can see that from this, if in the left panel are the reasons for using for non-medical reasons, and the reasons for using for medical reasons, they're not really that dissimilar. So there's kind of a gray area in that distinction. In recent years, some of the drugs that are best known for recreational use, that we're familiar with for recreational use, are now being considered in psychiatric treatment, so in a medical context. And the most common examples and I'll talk about two of these, the examples I've given here are MDMA or ecstasy, psychedelic drugs. There's also talk about using cannabis for medical purposes, and nicotine has also been raised as a possibility for medical treatments. And I'm going to give you some data from our laboratory on the first two of these, on MDMA and psychedelic drugs. So how do we go about testing or demonstrating? So that the drugs have acquired a reputation from non-medical use, and there are a lot of claims of unsubstantiated, sort of anecdotal claims that this makes me feel better for this, and this helps me sleep, and this helps my anxiety or my depression. So there's a lot of uncontrolled information available, especially from the non-medical, from the recreational use group of people. And so our challenge in our laboratory studies is to figure out how to really empirically demonstrate that these drugs are having the effects that people claim they have. So how do we go about doing that, showing that recreational drugs might have therapeutic value? And so I'm turning now to, I'll turn to controlled psychopharmacology studies. So what are the benefits? What do we need from these studies? I'm just going to see if I can find the pointer. I've got it right here, sorry. And it's hard for me to point because maybe I won't try and I'll just read them one at a time. So first, one of the first important things that we can do in our controlled studies is to ensure that we've got an exact dose. So a lot of the doses of drugs that people use that they get on the street are completely uncontrolled. And the purity of the drug, of course, is also that when the DEA analyzes street samples of drugs, they find that there's a very wide range of constituents of the drugs, and often they don't contain any of the drug that they're purported to contain. So in our laboratory studies, we can ensure the dose and the purity of the drug. We can control subjects' expectancies, and this is a really important one because when people use drugs in the natural, non-laboratory or non-medical settings, they come in with very strong expectancies. Nobody does microdosing or does MDMA without having very strong expectations of how it's going to make them feel. And those expectations, we know, can influence their responses. So our responsibility as psychopharmacology researchers is to try and separate the expectancy effects from the pharmacological effects and see what's really truly attributable to the drug. We also characterize the users very carefully. When the drug is used in a broader non-medical setting, we don't know who it is that's using the drug. They might have pre-existing psychiatric disorders. They might be taking other drugs. There might be all kinds of historical characteristics that influence their responses. So in the laboratory, we can control the participants. We can use quantifiable outcome measures. Again, this is hard in the natural situation because people make all kinds of claims and they're hard to quantify. So this one makes me feel more spiritual, or this one makes me feel more at one with the world, and those are hard things to measure. So in the laboratory, again, we can get quantifiable outcome measures. And we need to include a large enough sample that we can see whether this is true for a group of people and not just an individual one at a time. There are kind of two main ways to look at the effects of these drugs. One is clinical trials, where you give the drug to a large population of patients and see whether the drug makes them better. And then the alternative is laboratory-based studies, so small-scale laboratory-based studies where you give a drug and placebo and study how the drug affects people's behavior. And that's what we do, and I'll tell you about today. So here's an outline of what I'll talk about. First of all, I'll say a little bit about the methods that we use in human psychopharmacology. Then I'll present some data with MDMA and with LSD, and talk a little bit about challenges for the future. So here are some of the methods. First and foremost in any studies that we design and think about has to be safety, and that includes ethical issues and regulatory issues. So we need to get approvals from several levels of government and university institutions as well to make sure that we get approval. And we take this very seriously. Of course, we're working with psychoactive drugs, and there's a good possibility that people might have adverse responses. And so our first priority is that we don't do any harm in conducting these studies. The participants in our studies are typically healthy adults, young adults between 18 and 35. Their normal weight to control for differences in body weight. We screen them very carefully to make sure they don't have any medical or psychiatric problems, including drug use problems. The studies are done double-blind and placebo-controlled. So they're typically within the same subject. We give both drug and placebo on separate sessions. And we don't tell people in our studies, we don't even tell people what class of drug they're going to get. So we tell them you might get a stimulant or a tranquilizer or a hallucinogen or a alcohol. We give them a range of different possibilities to minimize expectancy. So again, I can't emphasize how important that is, because that might confound our results. So double-blind and placebo, so neither the experimenter nor the subject knows exactly. The experimenter that's interacting with the subject doesn't know what drug they're giving, basically. We test our subjects in a comfortable living room-like environment. It's in the hospital, so help is close at hand should we need it. And we have 3 categories of outcome measures. One is subjective effects, so how does the drug make you feel? A second category is behavioral effects, so how does it affect your performance on, say, measures of impulsivity or measures of memory, so that's more of an objective behavioral measure. And then the third category is physiological measures, so that might be heart rate or blood pressure, or it might be brain imaging to look at how it affects their brain function. So that's kind of a summary of the methods that we use. And this is just a picture of a typical laboratory room where they need to sit there for between 4 and 6 hours, and so we have some movies for them and comfortable furniture, and we give them lunch if that's appropriate. Typical study session is 4 or so hours. They come in and provide all kinds of tests before they first begin the session and make sure the women are not pregnant and that they haven't used any drugs. Then we administer a drug and allow some time for absorption, and then have a period of behavioral testing in the middle of the session when we expect the peak drug effects. And we also, at regular intervals, we measure their heart rate and their blood pressure and get subjective ratings of how they're feeling. So the first drug that I'll talk about is MDMA, or ecstasy, sometimes referred to as Molly, which is, as I mentioned, recreationally. It's used at raves and in party situations. The full name is 3,4-methylene methamphetamine, and from the name of the drug, you know right away that it's an amphetamine-like drug, and it shares many characteristics, both in mechanisms of action in the brain and also behavioral effects with amphetamines. So it's similar to other stimulant drugs and produces effects that are stimulant, but it has something unique, and it produces what people describe as pro-social effects. It makes people feel more connected with other people compared to other stimulant drugs. And so that's kind of been a theme of the work that we've been doing over the last 10 or maybe even 15 years to see what it is that's different about MDMA and compared to other stimulant drugs. And can we characterize that with psychological tests, or is there differences in brain function, or is there anything that we can do to figure out to distinguish those the MDMA from other stimulants? So it acts on the same neurotransmitter systems, dopamine, norepinephrine, and serotonin, but the MDMA has a relatively greater effect on serotonin. So it's thought that its pro-social effects are probably related to its effects on serotonin receptors. So here are some of the effects that we and others have studied in recreational users. So first of all, the font on the display here has changed to something entertaining, and it's interesting that it's interesting that you can't see it. I think maybe I'll just walk over here and. Okay, so I'm sorry, I'll switch back and forth. So it's used at dance parties and with strangers. And that's already a little bit of a clue. When young people are at a dance party, they want to be able to, they like a drug that makes it easier for them to interact with other people. So that's kind of a little bit of a clue as to what we're looking for and how the drug might be different from other stimulants. So we've done some double-blind studies. We've looked at self-reported feelings, so people report subjectively that they feel more sociable after MDMA. They talk more, they smile more, and they interact socially. They become less sensitive to negative emotional expressions. So if you show them pictures of angry or threatening faces, you need to show the face with a stronger expression in order for them to be able to successfully detect the emotion. So we use graded pictures of angry expressions from neutral, and then it gets very gradually becomes angry, and they need more of an expression under the influence of MDMA to be able to identify. And actually that fits in nicely with people who are in a social situation and then they're a little bit anxious or they want to relax a little bit, if the drug changes their perception of how other people are seeing them, then they're not going to be as inhibited in interacting. So if I look at you and you're frowning a little bit there, if I'm under a drug influence and I don't see the frown so much, then it'll be easier for me to interact, so basically. All right, so it also decreases sensitivity to social rejection. So there's a little computerized task that's called cyberball, where people play a game with another partner, and then at some point they get rejected, and they are no longer included in the game. And it actually induces some feelings of rejection and negative mood, and the MDMA reverses that. So I'm going to go over here, although I can't see that far, so sorry. And also, one of the studies I'm going to show you is that it increases the pleasantness of social touch. Okay, so here's just some data. Here we simply ask people on a 100 millimeter line, do you feel sociable right now? From not at all, over on the left, to very sociable, or as sociable as I've ever felt on the right. And so this is a study that was done with healthy volunteers. 40 people, they had 4 sessions, and they took capsules that contained placebo, a low dose of MDMA, that's 0.7, a high dose of MDMA, that's 1.5 milligrams per kilogram, or 20 milligrams of methamphetamine. And so we're including methamphetamine because, again, we want to know the difference between MDMA and a prototypic amphetamine-like drug. And they rated how they felt on this adjective sociable on this 100 millimeter lines every 30 minutes. Over on the right side here, you can see a graph. On the x-axis is the minutes of the session. So that's the time passing during the session. And here we have the mean ratings of how sociable they feel. So you can see under the placebo condition, that's the blue bars, there's no change over the course of the session. And after the low dose of MDMA, that's the green bars, there's also no change in how sociable you'll feel. But you can see that both the methamphetamine and the MDMA increased feelings of sociability. So this wasn't enough. This particular adjective isn't enough to distinguish between the MDMA. Indeed, the drug is clearly producing the effect at the time course that we might expect at the peak drug effect, but they don't differ. Here's 2 other adjectives. Do you feel loving, and do you feel playful? And here, this is the methamphetamine. The purple line here is the methamphetamine, and this is the MDMA. So here, for both of those adjectives, you can see that we're beginning to see a distinction between the standard stimulant drug and the MDMA. So that's kind of heartening that there's some qualitatively different subjective experience with this drug. This is an example of a study that we did early on with brain imaging. And as I mentioned to you, the people become less sensitive to negative expressions. And so, in this study, it's been reported by many investigators that when people view angry or threatening faces, it increases activity in a part of the brain called the amygdala. And so we were interested in whether this drug might dampen the response to this activity in the amygdala. So we gave them MDMA at the higher dose, and it reversed the increase. So here are some of the faces that the subject viewed. Here is an image of the fMRI image that we obtained. And here it's a little simpler to look at what happened with the mean scores. So an increase, the first of the 3 bars there is the placebo condition. I think there are only 2 bars. The first of the, we had a lower dose of, it was placebo and then a low dose of MDMA and a higher dose of MDMA. When you gave them placebo and you showed them these faces, the amygdala activity increased. And then at the higher dose of MDMA, the amygdala activity actually decreased. So this is consistent with what we might have expected if we thought that the MDMA was dampening the brain's response to a negative emotional stimulus like this. Another study that we've done a little bit more recently has been looking at the pleasantness of social touch. Here, often users of MDMA, recreational users, claim that the drug it's hard to really say how this happens, but they enjoy touching things, and especially apparently kind of like soft furry toys and things like that. There's no technical way to say it except that that's sort of an anecdotal report that people under MDMA like to touch things. So it turns out that there's a standardized measure of pleasantness of social touch, and it has to do with a very gentle stroking of basically of your forearm. And there's a social touch and then a not so social touch. So the social touch is a slow stroking, and if you start thinking about it, it makes sense. You stroke your cat or your child or somebody else at a slow rate. This is 3 centimeters per second. And then they have, as a control, they have fast stroking, so that's 10 centimeters per second. And so our question here was whether does MDMA increase the pleasantness of the social touch? And this is what we found. Indeed, we found, this was a study where we used placebo and 2 doses of MDMA, and then the 20 milligrams of methamphetamine as well. So we wanted to know whether the MDMA did something different from a standard stimulant. What we've plotted here is, first of all, on the left-hand side with the 4 bars on the left is the slow touch, that's the social touch, and then on the right-hand 4 bars are the faster and non-social touch. And you can see overall, the ratings of pleasantness of the non-social touch is lower than the ratings of the social touch. And this is the black bar here corresponds to the placebo session, and then you have the low-dose MDMA and the high-dose MDMA, and you can see the drugs significantly increased their ratings of the social touch. And interestingly, methamphetamine did not do that. So here's an example of an outcome measure where we saw differentiation between the two. Even more recently, we've done a study looking at feelings of social connection. So this is something that people often report. They report feeling connected with other people. So we wanted to know whether either MDMA or methamphetamine increased how connected people feel after they have an informal conversation. So we had them, actually we had a confederate, they were in the session, and for 45 minutes they had to have a sort of small talk conversation with a partner, with somebody that they'd never met, a same-sex partner that they've never met. So we had one study where they got methamphetamine or placebo with 2 different partners. And then in the separate study, they got methamphetamine versus placebo, again, with 2 different partners. They had this 45-minute conversation, and they rated how connected they felt with their partners. And just here are the results for the MDMA part of this study. This just shows you, this was just a question that they standardly complete. Do you feel a drug effect? This is, again, over time, over the course of the session. And the black bar here corresponds to the placebo session, and this orange bar corresponds to the MDMA session. So clearly, they're experiencing a drug effect at the time that we expect them to. And this pink or cream-colored bar in the middle corresponds to the time when they had that 45-minute conversation task. And here are the results. How much did you like your conversation partner? The black bar is the placebo session, and the orange bar is the MDMA session. So they liked their partner more after they got MDMA, and they also felt that the partner cared more for them as well. So we had maybe 8 or 10 of these kinds of questions, and on each of the questions, people reported feeling more connected with their partner. One thing I didn't mention is that one of the physiological mechanisms that is thought to mediate these feelings of connection with MDMA is the hormone oxytocin. So oxytocin is kind of a bonding hormone. It's involved in both mother-child bonding and also in male-female pair bonding. And there's a pronounced increase in levels of oxytocin after MDMA. So it's tempting to think that these feelings of connection are related to oxytocin. So in this study, we also measured oxytocin levels. This is their oxytocin levels after the placebo session, and this is the MDMA session. So as other people have reported as well, we see an increase in oxytocin levels. And to the right here, we decided to look at the correlation between this increase in oxytocin level and higher feelings of closeness, basically, with the MDMA. And here we saw a positive correlation. So higher levels of oxytocin, more feelings of closeness. Then we went ahead and also, as I said, we did this same experiment with methamphetamine. And so here we see a little bit smaller drug effect with methamphetamine, so the doses aren't matched exactly. But this is, again, the time of the conversation. And to our surprise, we saw that methamphetamine also made people feel more connected with their partner. So they also, on all the same questions that MDMA made them feel connected, so did methamphetamine. So it kind of raises an interesting question. I mean, we've gotten interested in MDMA in the context of psychotherapy, but we've just focused on MDMA only. And so there's a possibility that other stimulants might, if they were tested under the right circumstances, might have some of the same effects. And I'll get to the clinical effects in a moment. But so this was surprising to us that the methamphetamine also would increase feelings of a connection. We just didn't expect it from the self-reports. So a summary of, and I can add to that also, we did see a small increase in oxytocin levels, but that was not correlated with feelings of connectedness. So it was a little bit of a dissociation. So the MDMA increases oxytocin to a greater extent, and the oxytocin levels after methamphetamine are not correlated with feelings of closeness. So just to summarize what I've told you with MDMA, it increased feeling sociable, the pleasantness of social touch, feeling connected, and it decreased neural responses to negative responses. And so, negative emotions, I'm sorry. So these effects are all could contribute to recreational use. But these same effects could also contribute to therapeutic use. So MDMA is being used in phase 3 in clinical trials to treat post-traumatic stress disorder. And some of the very same effects that we see that would facilitate social interactions in a social situation might also mediate the beneficial effects in a therapeutic situation. So MDMA as an adjunct in psychotherapy. So in the case of MDMA, they give the MDMA very much in the therapeutic context. So it's as though they believe it enhances the interaction between the therapist and patient, basically. So it's not just the drug experience per se, but rather some combination of psychotherapy and MDMA. And how that works is yet to be discovered. So as I said, MDMA is in phase 3 clinical trials for psychotherapy, for PTSD, and it seems to be tremendously successful so far. Remains to be seen how it functions more generally. Okay, so how might those same effects be relevant to psychotherapy? Decreased perception of negative emotions. Again, in the therapy situation, if you feel less judged, you might be more willing to deal with difficult situations or thoughts. Increased feeling of connection or liking of the therapist, for example. Increased pleasantness of social touch. Now, in most of psychiatry, social touch is completely banned. But in these MDMA PTSD trials, social touch is very much part of the treatment. So they sit with the patient for hours and they do a lot of touching and reassuring. And so this is kind of new territory for psychiatry. And of course, it was banned for a good reason, because it was misused, and people have to step very carefully. But in this case, there is social touch in the MDMA PTSD trials. Increased oxytocin levels, we don't know that, whether the oxytocin or the increased oxytocin levels could mediate some improved psychotherapy connections, basically. And then facilitated fear extinction, so people are trying to get rid of negative memories, and so the drug might facilitate that. So what's next for MDMA research? Well, we have to figure out how exactly MDMA affects psychotherapy. We don't know that. Are the drugs limited to MDMA, or do they also occur with other drugs? And I've also given you a couple of examples where methamphetamine does something similar. So under what circumstances might they be both effective? And then currently MDMA is being used for PTSD, and it's possible that it would be effective for other therapy situations as well, and that remains to be determined. Okay, that's the end of what I was going to say about MDMA. I'm going to switch over now to psychedelic drugs. And of course, I'm sure you're familiar with LSD, psilocybin, mescaline. So these drugs are used recreationally, very widespread use of psychedelic drugs. 8% of young adults have used a psychedelic drug at least once in 2021. And the reasons for use include, as I mentioned earlier, curiosity, spiritual journeys, and self-discovery. In the therapeutic context, they're used in two major and different ways, or these are just exploratory studies, the therapeutic studies. None of them are FDA approved, and they're not in widespread, they're not being used on a large scale at all, so they're just currently being investigated. The most common example that you hear about in the news is these single high-dose clinical trials for a range of different psychiatric symptoms. So here in these studies, basically, it's a very large dose. The session lasts something like 8 hours. There's several sessions of preparation before the drug experience, and then several sessions of integration after the drug experience. So it's a big experience, and it's really the drug experience itself. It's not so much drug interacting with psychotherapy. So the therapeutic use, so high dose is one thing, and then these low doses, which is what I'll be talking about because that's what we've done in our lab, are that there's a possibility that these very, very low doses have some beneficial effects even without the psychedelic experience. Interestingly, back in the 1960s, low doses of LSD were used in the context of psychotherapy, and it was called psycholytic therapy. So there is a history of it, and of course the psychedelic research was all stopped in the 70s. But there was reasonable evidence that these low doses might actually be useful in a therapeutic situation. So, okay, so I've just said a lot of this already, that high doses are being used to treat psychiatric conditions in research studies. And here are some of the indications that they've been used for. So end-of-life anxiety is a very common, or it's being done in several sites. Depression, it's been effective with smoking cessation. And it's been actually used with alcohol dependence as well. Turns out that the person who wrote the book on AA and developed the AA procedure, he was actually able to quit his alcohol use after an LSD experience. So there's a long history of somehow these drugs changing people's habitual behaviors. And as I said, the treatment is combined with intensive psychotherapy, including preparation sessions, 8-hour drug session, and then integration sessions. Here's an example of a very recent, this just came out maybe 2 weeks ago or something, of some results from an antidepressant trial. And here it was with psilocybin, which is actually very similar to LSD in many respects in terms of mechanisms of action and in effects. The doses are very different, but the effects are similar. They were looking at patients with treatment-resistant depression. And this is the x-axis is time. So the first is a baseline visit, and then this is immediately after the drug experience, and then this is weeks after the administration of the drug. And this is ratings of clinical depression, basically. The top bar, so and a decrease means improvement. So a larger decrease in depression means that they're doing better. So the darkest line here is the higher dose of psilocybin, and the gray line here is essentially a placebo dose of psilocybin. So they gave a little tiny dose of psilocybin just so that they could say they were getting psilocybin in each of the doses. But it seems like quite an impressive outcome that lasts over an extended period of time. So this is just one example of many that show promise with psychedelic drugs at high doses. So there are many challenges in doing these psychedelic studies. One of them is that it's difficult to control expectancies. So in these high-dose studies, there's no way that you can not tell people that they're going to have this experience. They know they're going to have it before, and the preparation sessions are setting them up for what to expect before. So it is absolutely not blinded, which makes it complicated to interpret the outcome. So it could be that the expectancies of getting a benefit from a big psychedelic experiences are controlling the outcome measures. We don't always know which outcome measures to use, so we know that in some way the drug is changing behavior, but it could be changing any one of a number of behaviors. 5 minutes, okay, I need to move along fast. And then how does it interface with the psychotherapy? And then one of the big questions that comes along in these high-dose studies is, do you really need this big psychedelic experience in order to get the therapeutic beneficial effects? And that's where our studies with the microdoses might shed a little bit of light. So microdosing might be a way to study the effects of psychedelic drugs without the powerful subjective effects, so without the trip. And so people, as you probably know, take very low doses, basically a tenth of the dose that you need to trip, and they take it every 3 or 4 days over an extended period of time, and they claim incredible benefits on all kinds of dimensions, which I'll show you here. So here are some of the popular books that have been written on microdosing, so you can see them here. And here are some of the claims that are made: a step-by-step manual to improve your physical and mental health, a practical guide to upgrade your life, and then made a mega difference in mood, marriage, and life. So these are things that are hard for us to study in the laboratory. They're not very quantifiable. So it's our job to come up with something that might account for some of these very strong claims. So the question is, what does the microdosing do? Who benefits from it? And how does it work? And there are very few controlled studies. And there are reasons for both optimism and pessimism. For optimism, that it's so popular. And there are some plausible neural mechanisms that could account for this. In fact, in particular, that it acts on serotonin, which is involved in antidepressant drugs. It also has anti-inflammatory and neurogenic effects. And there's a little bit of indirect evidence in laboratory animals with these repeated very low doses of LSD. Reasons for skepticism: that, as I said, the expectancies have deeply confound any claims that people make. The pharmacology is not very well understood, and I'm always concerned about the very wide diversity of the benefits that people have. So improved creativity, productivity, focus, flow, improved empathy, just every descriptor under the sun. And no single drug could possibly do all those things. So again, our job is so a challenge for us actually is to figure out what exactly to measure. So the design of the study that we did, we had healthy adults. It's actually more than 36, it was a little bit more like 60. And we tried to get people who reported some negative mood to begin with, so some discomfort, psychiatric discomfort. The design of the study was it was a double-blind between subjects in this case. They had 4 sessions, and they came every 3 or 4 days to the lab for about 4 hours. And they were randomly assigned to one of 3 groups: a placebo group, a low-dose LSD group, or a high-dose LSD group. And then we measured a whole range of questionnaires and behavioral tasks and outcome measures. This is just to give you an idea of the dose. Over on the right-hand side, the graph on the right shows data from another group in Switzerland that gave high doses. So they give 100 and 200 micrograms of LSD, which is enough to have a trip. So that's how much the people rated feeling a drug effect over on the right when you give a high dose. And this is data from our study. This was placebo, and then 6 micrograms, 13 micrograms, and 26 micrograms. So we did this study first to see what kind of doses we'd have to get. So this is how much do you feel a drug effect, but not specific, just an overall feeling. This is a schematic of the study. Basically, people were screened, and they were randomly assigned to either the placebo group or the low-dose group or the high-dose group. They participated in 4 sessions. They were each about 4 hours long, and they were separated by 2 or 3 days. And so they got either one of these 3 conditions, and then we had also a follow-up test a couple of days, 3 or 4 days after the last session, to see if anything had changed. So this is, first of all, how did they feel on the very first time that we gave them the LSD? So this is what's called a peak change score. So it's the change from before they took the drug to whatever the highest point was during the session. And so here, and this is first of all on measures of how vigorous do you feel, how energetic do you feel. The first bar on the left is the placebo session, and then the low dose LSD, and then the higher dose LSD. So you can see over the course of a session, of a 4-hour session, if you don't give them any active drug, they feel sleepy. So there's a negative response on vigor. So it's boring. They just sit there for that many hours. But then you can see when you give them LSD, there's a pronounced increase in feelings of energy and vigor. And this is actually very similar to what we see with the stimulant amphetamine as well. That effect, though, dissipates over those 4 sessions. So it basically declines. By the 4th session here, you can see that there was basically no change across between the placebo and the 2 drug conditions. So yes, we saw a little bit of increased vigor, but it didn't continue over those days. And then similarly with ratings of depression. So this is, again, over on the leftmost set of bars. This is not working. On the leftmost, this is placebo, this is low dose, and this is high dose of LSD. You can see on the first day they're reporting some decrease in depression, but then by the 4th time that we give them the drug, it's no longer there. This is, you might want to ask, what did they think they got? So we did ask them what they thought they got. These are the 4 sessions for the placebo group. The middle ones are for the 13 microgram group, and the ones on the right are for the higher dose, the 26 microgram groups. The red here corresponds to, do you think you got a hallucinogen? And the gray at the bottom, do you think you got a placebo? So you can see there's a bit of an increase in, if you look across the placebo and the low dose and the high dose, you can see that some people are reporting that they're getting a hallucinogen, but not profound, and not most of the subjects, basically. So a lot of people are interested in this relationship between people identifying the drug correctly as LSD and then having outcomes. And so they've studied that in kind of non-laboratory situations. Okay, so summary of the LSD study, we saw some initial effects on mood, and but that declined with repeated doses. We saw no lasting effects on mood, cognition, or emotional function. So on that session that we had after the 4 sessions, there was no change at all. And there were no changes on any of the behavioral measures, so measures of emotional reactivity or sensitivity to negative stimuli. There was just nothing on any other measures. So our study provided really very little support for this idea that you have beneficial effects from repeated microdoses. On the other hand, it's really hard to conclude from one single study like this that the phenomenon that all these people are reporting is poorly founded. So there are infinite number of, anytime you have a negative study like this, there are a lot of questions that remain unanswered. So would it work more effectively with different subject samples, with different doses or a longer period of dose? We only gave it over 2 weeks, so if you gave it over 4 months, maybe there would be some beneficial effect. And maybe we measured the wrong thing. Maybe we didn't get the right outcome measures. So just to kind of summarize, I've talked about some old uses of MDMA parties, and then the newer uses is its use in psychotherapy, and maybe some of the same effects some of the same behavioral effects of the drug are contributing to both of those settings. I talked about psychedelic drugs, so old use for tripping and having an interesting time, and then the newer uses for psychotherapy. And then same is true for cannabis. It has historically been used to get high, and they're now also considering doing clinical trials to see whether there are therapeutic benefits of cannabis as well. So where do we go from here? We do need to move beyond this stereotypic view of medical versus non-medical, even though I set it up for you. That's kind of the mindset that a lot of us go into this with. We need to identify which drugs are effective and which of their effects influence therapeutic outcomes. optimize the use, how the drugs interact with the psychotherapy that goes on. We need more controlled studies, and we need to monitor the participants. Once we get into clinical trials, we have to monitor whether any harm is being done. So I'm going to stop. These are some of the people that have worked with me. Anya Bershad, Hannah Mola most of these people are postdoctoral fellows in the lab. Royce Lee is the psychiatrist that I work with, and the work has been funded by the National Institute on Drug Abuse and the University of Chicago Institute of Translational Medicine. And thank you very much for your attention. I'm happy to answer questions. There are 2 microphones on either side, and probably good for you to use the microphone because the people in the back won't be able to hear you. Yes?
Yeah, I understand during the Cold War that there was a lot of interest in using LSD for interrogation and other purposes. And I'm wondering, in this era, is MDMA research funded by any particular agencies with an interest in perhaps pacifying people through chemical empathy in prisons, or perhaps as a battlefield psychotropic weapon to make your enemy's soldiers less aggressive and more empathetic?
Well, it's a good question. And I think it draws attention to some of the risks of studying these drugs and even understanding how they could be misused. They could be used in a context that's not socially acceptable to most of us. So for now, the work is being done in research contexts, so it's very controlled by institutional review boards and by oversight committees. Once drugs like this get out into the general use, if they get to the point where they're marketed and more widely available, there is a possibility that they could be used by people for purposes that we wouldn't agree with. So it's a concern. Yes?
First of all, I want to say it's very exciting, the work that you're doing. It's
Dose. And so then, at least that we're saying, I'm not sure whether you were referring to people's reports of what they experienced or what we found. But when we study these low doses, it's variable in part because the doses are they're just on the edge. Secondly, people vary a lot in their responses to LSD. So even if you gave higher doses, different people experience different things. And people have theorized about that. Maybe we're measuring the wrong thing. Maybe it doesn't do a single thing, but rather turns up the volume of whatever is going on in that person at that time. And so if that's the case, it makes it really difficult for us to measure. With regard to neurogenesis, you were asking, I think you would really just see that with repeated doses. And so I'm not sure that there are, I might be wrong, but I'm not sure there are, so neurogenesis refers to growth of neurons, new growth of neurons, which until recently it was thought that once you're grown up, you don't have that. And now people realize that neurons can't form new connections. And so the new connections are one hypothesis for the increased feelings of well-being. To my knowledge, it's usually with repeated doses, and I don't know whether a single dose does that, but I'm going to have to look on Google to see that.
Okay, thank you.
Yeah.
I'd like to go back to something you mentioned earlier, and that's kind of popular in the news and popular science as well, is the smoking cessation or the alcoholism effects. How much of that do you think has to do with expectancies and intentionality? I know
That's
there's no
the million-dollar
answer,
question. I have no idea. It comes back to this question of whether you really need this big experience to see the beneficial effect. So one way to address that question, there are people who are trying to develop new compounds that have the same effect on the, some similar effect on the serotonin system, but don't produce this psychedelic experience. So that's going to be the question, is whether that's really necessary. But even, right, how can one big profound drug experience make you stop smoking? It's just, there is something mysterious about it. So that's what keeps us working.
Thank you.
Yeah.
Hi, thanks so much for sharing your work with us. I'm wondering if you have any plans to study the effects of combining psychotherapy with the drugs and integrating the planning and the integration piece of it in your lab.
I'm not really qualified to do studies with patients, so I think it's a really interesting question. The trouble is some of those studies are designed to make people better. So everything is oriented towards alleviating some suffering. And so it makes it really hard to build in the kind of experimental controls that I have the luxury to use in my laboratory. I am interested, though, just in what happens, apart from those preparation sessions and then the reconstruction session, just what happens with a therapist and a person under the influence of MDMA. What is it that's different? How does the interaction proceed differently? Do they like each other more? Do they feel more connected? Do they make more eye contact? Are they less frightened? What is it? That's something that would be a little bit more manageable. What happens within a session between a therapist and the person under the influence of the drug? So these are all hard questions.
Yeah, okay, thank you.
Okay. Yeah.
Hi, thanks so much. And I think my question probably is along the lines of what was just asked, but I was curious about what you would expect perhaps, or even recommend regarding these drugs after theoretically they're FDA-approved chemical entities in terms of whether they are administered in a clinical setting or, as you kind of indicated before, would be home drugs. Like, would they be something you would go to a clinic and you would be there with a therapist or two and you'd be talking to them and perhaps have some follow-up sessions versus you just take the drug at home and have fun with that. And also I think there's a huge kind of implication for our traditional medical model of how we pay for care. That would be kind of an episode of care of paying for a drug and the therapy altogether versus just paying for the drug. And it sounds like that this is a little outside of what you do, but I'd be really curious of your thoughts about that.
There are certainly proponents of making the drug available to everybody, but I'm not one of them. I think we're not there yet. These are powerful drugs, and they can be misused. They can be used by the wrong people in the wrong ways, and they can be used excessively. So I would recommend some level of medical oversight, or psychologists for that matter, but some sort of professional oversight when they're being used. But there are definitely people who want to make them available to everybody for everything. We've already learned that things can go wrong when things went wrong in the 70s, and they could go wrong in even other ways. So I'd say controlled and some kind of professional context.
Thank you.
Hi.
Hi. So first, thank you so much for bringing this into a little more of a normalized communication, normalized field, and then these are like, topics of conversation that we're having on a regular evening, so thank you. My question is, do you think that by breaking down the specific responses that we're measuring, we might be missing some of the bigger effects and lasting effects, 'cause especially when we looked at kind of the fading effects that we saw, but the lasting effects that you get from these experiences? So by measuring kind of the leg, the tail, the trunk, do you miss the elephant?
Yeah, it's possible, but as a scientist, I'd want to know, well, what is it then? What is it that changes the behavior then? If something related to the drug is changing the behavior, then you're almost saying like it's not measurable or it's not studyable, and that kind of goes against my nature. Yeah. But it's a great mystery, especially with the high-dose psychedelics, that they have this they have this transformative experience, and even the experience itself is a mystery. You know, how one of the defining features of the big doses is they feel that everything's really important. This strong, profound feeling of significance. Well, what does that mean? You know, there's not. They have thoughts. I'm sure you've read the Michael Pollan book, where one of the people have this profound thought, and the profound thought turns out to be, I'm mortal. You know, and so. But to the person, that was really important, and that had lasting effects. So I'm not sure I've really answered your question, except you're saying maybe we can't measure what it is that changes, and that's not satisfying to me. I want to try and measure it. Yeah. Hi.
Hi, thank you so much for your talk. I was curious to just get your opinion on like private industry offering up treatment plans with some of these drugs. Like I know of Innovative Ketamine opened in Chicago a couple of years ago, and I see their Instagram ads, and they're probably targeting young people to microdose ketamine. And there's also like Field Trip Health that I've heard of, that these private companies are growing really fast with maybe dubious claims.
That is one of the scariest things about this. The psychedelic research field and therapy field is completely being taken over by industry and people who have a lot of money to invest in it, and they want to make a lot of money from it, and they're in some sense, I'm not generalizing, but they don't really care that much about the clinical outcome or whether they want to minimize harm for their own interest. Anyway, there's a lot of controversy, a lot of talk about how much money is going into the psychedelic work, and how there are companies that want to just give the drug without any psychotherapy. So it's a scary thing where this is going now. And it's partly, I would say, that the NIH, the government funding, has stayed away from this. They don't want to touch psychedelics as medications for psychiatric disorders. And so then it's been taken over by industry. And it's a scary prospect to me. And so other things like that, if industry sponsors a study, then they have control over the data. And so that means we can't look more carefully at the data, at what other things, they own it, they control it. So the funding is a scary kind of undercurrent here. Yeah. Yeah.
Related question. It looks like your federal funding comes from the National Institute on Drug Abuse, right? Which in and of itself says something about the position of the federal government on these kinds of drugs. I'm wondering if you can talk about the changes that you've observed over the last, say, 10 to 20 years in terms of federal interest, government interest from NIH or anybody, in terms of looking at these drugs.
I think they've funded the first one or two. We have to stop soon. I see. Yep. They've begun to fund one or two of the study. This belongs in NIMH, mental health, in National Institute on Mental Health, not National Institute on Drug Abuse. The only reason I've listed that there is because early on we did a study with MDMA that they funded. And so I fitted in there that people are using these drugs. I justified it to the National Institute. People are using these drugs recreationally, and so we better understand how they work, basically. But to my knowledge, that's one of very few studies that the NIH has funded.
Okay, so we're not seeing a big sea change in terms of
federal
government interest.
We're not. Most of the studies, there are a lot of psychedelic studies going on. They're privately funded for the most part.
Thank you.
Yep. Carol, I think, where is it? Do we have, is this the last question? This is the last question.
Hi.
Hi.
Hi. I have a legal practice. I work with students who are in need of accommodations, of educational planning. They frequently have underlying neurotypical conditions, and I want to thank you for doing this research. These are kids who have caused me to learn how to stitch together crisis care, keeping these kids alive. Sadly, my nephew actually died last month from street drugs. And the message of purity and dosage, I repeatedly tried to explain to him, and he repeatedly told me he knew what he was doing. And so this work is so terribly important. It's so terribly important to cause these substances to come under some sort of pure manufacture, because the street drugs are not helping. And then with my kiddos with very treatment-resistant depression, I have this semester, the very first student I've worked with, we've decided to go on a leave of absence for some time because I think she needs 8 or 12 months. But her mother is desperate, and she has been bringing up all of these ideas. You know, what about we try this? What about we try that? There's a terrible desperation out there.
There is a need for more drugs. Yeah,
and
right.
so, so thank you for making it, getting us closer. I know it's going to take some time, but it's so important for me to be able to convey to my kids that it is being worked on, and to please just hang in there with clean pharmaceuticals.
All right, I appreciate it, and thanks for your work too. So, Carol.
Thank you so much, Dr. de Wit, for your research and for sharing your knowledge with us today. And I want to thank everyone in the audience for your questions. And it was a very kind of a firing squad there at the end. So really appreciate you all bringing the questions to the forum. And again, I acknowledge Dr. de Wit for handling that quite well. So thank you all. Let's give her another round of applause. I know it's forums like this that make me incredibly proud to be a UChicago alumni, and I think that I hope I speak for several of you in the room that having these opportunities not only to learn from esteemed faculty, but also to have that opportunity to have that critical conversation, to ask those difficult questions, and take the time to hear those really thoughtfully and thought-provoking conversations is one of the key elements that makes me think fondly of my time at UChicago. And so I'm really excited to be a part of the Alumni Association that can help to bring these types of forums to all of the alumni within our community and to help us maintain that life of the mind and that critical exploration that we all cherish so much during our time. So I really want to just acknowledge that thank you all for being here tonight. Thank you all for sharing in that conversation, and thank you all so much for maintaining that life of the mind that we all cherish so much. So once again, thank you all so much for coming, and an extra round of applause. Thank you so much, Dr. de Wit, for your time and sharing your research with us. And thank you all. Have a wonderful evening.